Hello everyone. So now we finished discussing our first topic in pharmacology, which is pharmacokinetics, which describes the effect of the body on the drug, or what the body does to the drug. And it was about the movement of the drug. It was about absorption, distribution, metabolism, and excretion, or ADME. Okay? Now we are going to discuss our second topic, which is pharmacodynamics, and that describes the effect of the drug on the body, or what the drug does to the body. Okay, so let's get started. We will suppose that this is a cell in our body, and on the cell membrane we have some molecule here, which is protein in nature. This molecule is a target for our drug. Okay, there is a molecule that binds to this target. This molecule could be our drug. Okay, any molecule that binds to certain target or receptor in our body is called ligand. Okay, so any molecule that binds is called ligand. It binds to a certain target. Mostly this target would be a receptor. Okay, so now we have this receptor here found on the cell membrane, but also we can find a receptor that is found inside the cell. Okay, and what would you expect the difference would be between the receptor on the cell membrane and this receptor inside the cell, that is found inside the cell? Right, the difference would be in the type of ligand that bind to this receptor. The receptor found inside the cell, or what is called intracellular receptor, this ligand should pass through the cell membrane to get into the cell, or to get inside the cell to bind to this receptor. So this ligand should be lipophilic enough so it can pass through the cell membrane, or the phospholipid bilayer of our cell membrane. Okay, so this ligand will be lipophilic, while the ligand which binds on the receptor which is found on the cell membrane is mostly would be less lipophilic. Okay, so the binding of a ligand or a drug to a receptor would result in an action inside the cell. Okay, and there is a cascade of events that happen after binding of the ligand to the receptor until we reach an action. These events are called signal transduction mechanisms. Okay, so now we have a target protein like receptor, and there is a ligand that binds to it. And as we can see, the shape of the ligand is somehow complementary to the shape of the site of the receptor in which our ligand will bind to. Okay, they are its shapes are complementary to each other. So it's like a key and its lock. So the binding of our ligands to our receptors follows a theory called key and lock theory. Okay, now let's have a look at how our drugs work, or how we think about making drugs. This is our heart here. Our heart rate, or number of heartbeats per minute, is increased through the action of a molecule called adrenaline. This happens by the action of adrenaline on a receptor called beta-1, and our heart rate is decreased through the action of a molecule called acetylcholine through the reaction or the action of acetylcholine on a receptor called M2, or muscarinic type 2 receptor. Okay, and the net result of the heart rate at rest, which is about 70 beats per minute, is the result of the action of these two ligands, adrenaline and acetylcholine. Adrenaline increases heart rate and acetylcholine decreases it, and the net result is the net of these two actions. Okay, so what if we have a patient that has bradycardia? Bradycardia is slow heart rate. In this patient, we want to increase his heart rate. So we can give a drug that acts on this receptor, on beta-1 receptor, to increase the heart rate. And on the other side, we can have a patient that has tachycardia, or high heart rate, and we want to decrease his heart rate. So we can give a drug that acts on that receptor, on M2 receptor, like acetylcholine, and by that it decreases his heart rate. Also, in these two patients, we can follow another approach. We can, in the patient of bradycardia, we can decrease the effect of acetylcholine, and that could be done by blocking the receptor M2 so that acetylcholine can't reach that receptor or can't act on it, and then we would have only adrenaline that works on the heart, only adrenaline, and so our heart rate would increase, because adrenaline now, or the action of adrenaline now, is unopposed by the action of acetylcholine. Okay, so now we know that ligand binds to the receptor. Okay, and the property of ligand binding to certain receptor is called affinity. So if there is a ligand that can bind to certain receptor, we say that this ligand has an affinity. And now we discussed two types of ligands. One that acted on the receptor, that give the same actions of adrenaline by giving an action, so it bound to the receptor and gave an action, and we discussed another ligand that bound to receptor without giving any action. It just blocked the receptor. Okay, so the property of giving an action after binding to the receptor, we call that property for a ligand, we call that intrinsic activity. So if a drug could bind to a receptor, it has affinity. If also it gives an action on the cell, it has intrinsic activity. Okay, the type of ligand that has affinity and has intrinsic activity together, we call that type of ligand agonist. Okay, and the ligand we discussed that was or had the property of binding to the receptor, so it had affinity, but couldn't get an effect on the cell. So this ligand has affinity, but it doesn't have intrinsic activity. This ligand is called antagonist or blocker. Okay, now there is a ligand that is between agonist and antagonist. This ligand can bind to the receptor and it has intrinsic activity also, but it is much smaller than the intrinsic activity of that agonist. So we can call that ligand partial agonist because its intrinsic activity is smaller than the intrinsic activity of the agonist. So this partial agonist has the affinity and it has also intrinsic activity but is smaller than the agonist. This partial agonist, by binding to the receptor, it gives an action that is smaller than the action of the agonist, but also it somehow doesn't allow the binding of the real agonist or the full agonist on the receptor. So we can consider it also as partial antagonist because by binding to the receptor, yeah, it's right that it gives some action, but it doesn't allow the full agonist to bind to the receptor. So we can call it also partial antagonist.